So we'll start with sepsis. We'll be covering these three guidelines in this. There is a talk in 2020 regarding the updates in the management, bacterial, and there are two GTG guidelines on sepsis. So sepsis, the classification of sepsis, there is a spectrum actually. So the first one is SIRS, which is systemic inflammatory response syndrome. If any two of these symptoms are present, so two or more are present. Either there is fever with temperature more than 38 degree or hypothermia with temperature less than 36 degree. Heart rate of more than 90 beats per minute. Respiratory rate of more than 20 breaths per minute or partial pressure of carbon dioxide less than 32. Either WBC count is more or WBC count is less, or there are a lot of immature cells in the peripheral blood supply. Okay, more than 12%, less than 4,000, or less than 10%, more than 10% immature cells.
Okay.
So, of these four criteria, if any two are present, so that makes the diagnosis of SIRS.
Okay.
Then, what is sepsis, and how do you differentiate it from SIRS? So, sepsis is like all these will be present. Any two of these will be present along with there is a documented evidence of infection. So, how it can be documented? Either there is blood culture positive, urine culture, or any of the cultures are positive, or on microscopy you have seen some bacteria.
Okay.
So, this is how you can confirm. Okay.
Okay.
Then what is severe sepsis? If there is organ dysfunction along with the sepsis, that is called as severe sepsis. So organ dysfunction means anything can occur. Either there is lactic acidosis, hypoxemia, kidney is affected, renal shutdown, oliguria, altered sensorium if brain is affected. So if other organ system are involved, then that is severe sepsis.
Okay.
Organ involvement. And septic shock, so it is shock if there is hypotension which is refractory to any kind of fluid resuscitation along with sepsis. So that is shock. So this is how the spectrum of sepsis has been classified. In pregnancies, there are some physiological changes, and these physiological changes mimics the signs and symptoms of sepsis. Like in pregnancy, also normally there is hypotension, systemic vascular resistance decreases, blood pressure decreases. So these hypotension is also there in sepsis. Heart rate increase during pregnancy, blood volume increase. Respiratory rate, there is some sort of respiratory difficulty in pregnancy because the diaphragm moves up. So there are respiratory symptoms in the sepsis. Similarly, renal blood flow, renal plasma flow, GFR increases. And in this also there is vasoconstriction ischemia. So there are some renal changes. Pregnancy is also a hypercoagulable state, and in sepsis also because the DIC sets in, so there is hypercoagulability. So symptoms almost mimic. So in both pregnancy and sepsis, it is very difficult to differentiate when the patient is actually affected.
Okay.
Okay.
What does it mean, ma'am? Antithrombin and protein C may or may not increase.
May or may not increase.
Like
Yes.
it may increase or decrease.
Or may remain the same.
Or remains okay.
Usually, antithrombin and protein C are the same. There is no change.
Okay.
Then, what is a definition? That was a definition according to the NICE guideline. Now, there is something called a sepsis 6 bundle or sepsis 3 definition. So, international consensus has also given the sepsis and septic shock definition, which is based on some score. So, if there is the organ dysfunction under sepsis, they have classified, they've given various points, and based on those points, you calculate the score. So, if there is an evidence of infection, like if there is blood culture, urine culture, or smears positive, along with the SOFA score, we call it SOFA score.
Okay.
If it is more than equal to 2, it is called sepsis. So, this is sepsis 3 definition of sepsis. SOFA stands for sequential sepsis related organ failure assessment.
No, one is if SOFA score is above 2.
With evidence of infection.
Okay.
Is sepsis.
Okay.
This is
And another one, organ dysfunction under sepsis. What are the three definitions actually?
This so I've already told, no, what is SIRS, what is sepsis, what is severe sepsis, what is septic shock.
Oh, okay, okay,
This is one definition,
okay.
which is given by the NICE. Then this
Mm,
sepsis 3, there is sepsis 3 bundle, which is by the international consensus. They have also given one definition, which is
oh, this
based on this
sepsis 3
SOFA
means
score.
it is 2 plus 1. That one is infection.
Yes.
Okay.
Okay. And this is sepsis. So SOFA score, they have classified. This is how you calculate the SOFA score. You don't need not remember it, just read it so that you have a little bit idea. I have not seen asking like
Okay.
in any exam asking calculate the SOFA score. So just
Okay.
have an idea of what it is. So in the respiration, they have seen PaO2 by FiO2. If it is less than 300, then it is score is 2. Platelet
Okay.
count, if there is thrombocytopenia less than 1 lakh, it is SOFA 2. Bilirubin, if it is more, SOFA 2. In CVS, they have taken this arterial pressure, and if the vasopressors are required, it is SOFA 2. CNS, based on the arousal status, if the patient is alert, it is 0. If the patient is arousable only on pain, then
Mm.
that is 2.
Bilirubin is it 3.2?
No, it is in
30.
micromole per liter. We
Oh,
do not use
so
this.
30.
We use mg per dl. We'll have to convert it.
Okay.
Okay, creatinine less than equal to 90 or more than 120. So I have not seen any question where you have to calculate the SOFA score. So just be aware that there is some score like SOFA, and
Okay.
it is used for sepsis definition. And for documentation of the infection, how can you document? Either there can be general variables where fever, hypothermia, tachycardia, tachypnea, impaired mental state, uh, considerable edema or fluid imbalance, hyperglycemia, or discoloration of the skin. So these
Mm.
are general, or WBC count is more, or there is leukopenia, or immature cells are more, CRP is high, uh, arterial hypotension is there, lactate is more, lactate more
Okay.
than equal to 4. This you have to remember.
Mm.
Anyways, I'll be discussing more about lactate because questions have been asked on this point.
Okay.
Decreased capillary refill, organ dysfunction in terms of if there is oliguria, creatinine, all this, thrombocytopenia, this we have already studied. So this is how you uh, call the patient to have sepsis or not. Quick SOFA you have to remember. So quick SOFA score you have to remember, and in clinic general practice also you can use it to
Mm.
for this also, if the quick SOFA score is more than equal to 2 along with evidence of infection, that is also called sepsis. So it's a quick score where you are using just 3 parameters. So this you have to remember. Here you are using SBP, respiratory rate, and altered ventilation, and you classify 0 or 1. SBP more than equal to 90, 0, less than 91, respiratory rate less than 25 is 0, more than equal to 25 is 1. Altered ventilation, if the patient is alert, that is 0, not alert, it is 1. So this you have to remember. Okay.
Okay.
Three parameters are SBP, respiratory rate, and altered ventilation.
Okay.
And if it is more than equal to 2, same as SOFA score, along with evidence of infection, it is called a sepsis.
Okay.
Then there is something called a sepsis 6 bundle. So what is sepsis 6 bundle? So in this, in any patient who comes with sepsis, you have to perform this. You have to take 3 and give 3. What you do, take 3, what all 3 in terms of investigations and monitoring, you take cultures, you send blood lactate, and do early urine output.
Okay.
And give them oxygen, IV fluids, and antibiotics.
Oh,
Antibiotics should be started ideally within 1 hour of that diagnosis of sepsis. So this you have to remember what is included in sepsis 3 bundle. You take 3, take culture, send blood for lactate, do an early urine output, start oxygen, IV fluids, and antibiotics. Okay.
okay. Like we have to wait for the report anyhow.
No, you
Or
don't.
we
You
start. Okay.
Yeah.
Okay.
So it is you. You are the evidence of infection could be in the terms of temperature or
Oh, like a specific antibiotic.
no, you start broad spectrum. I'll come to that.
Yeah.
Initially, you
Okay.
start broad spectrum. I'll come
Okay.
to that. Okay.
Okay.
So, you not because cultures will take more time. It will take around 48 hours, 72 hours. So you cannot wait for that long.
Okay.
Okay. So, according to the Sepsis 6 bundle, it showed a 25% relative risk decrease in the morbidity if you apply this. Like if you
Okay. What
start
is
the
SSC?
Sepsis 6
Sepsis.
bundle,
That C stands for?
it care bundle.
Okay.
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 So, if you like use this and adopt this Sepsis 6 bundle, 25% decrease in the relative risk of
Okay.
mortality and morbidity. Okay.
Okay. Okay.
So this is the same with, and this has to be done within the first hour of diagnosis. Okay.
Okay.
As soon as it is diagnosed, you send the you. What are the three things that you take, and what are the three things you give?
Culture, lactate, and hourly urine.
Okay. And what do you give?
So we give oxygen, fluid, and antibiotic.
Yes. And fluid at a rate in pregnant patients, you give it already because already there is overload. So you give
Okay.
it at 20 ml per kg. In non-pregnant, it is 30 ml per kg. So this
Okay.
also you have to remember rate at
Okay.
which you give the fluid. Okay. So
Okay.
non-pregnant, you give it at 30 ml per kg.
Okay.
Pregnant, you give it at 20 ml per kg.
Okay.
Okay, and about venous lactate. So there are many questions on this. So they give you a scenario in which they mention the patient is of sepsis and they mention about the lactate and they ask you what will you do. So if the lactate is more than 2, so
Mm.
then you have to prompt critical care input. Okay, so you have to start your management, ship the patient to critical care, start management. If it
Okay.
is more than 4, despite IV fluids and requiring the use of vasopressor should lead to initiation of, then you have to start invasive monitoring, and
Okay.
target should be CVP should be more than equal to 8,
Mm.
oxygen saturation should be more than equal to 70%,
Okay.
then this arterial oxygen saturation should be more than mixed venous saturation more than equal to 65, central venous should be more than 70, and oxygen saturation should be more than 94%. This should be
Okay.
your target.
Okay.
Okay. Then when will you transfer the patient to ICU? So if there is hypotension or serum lactate is raised,
Mm.
if there is pulmonary edema, patient requires mechanical ventilation or airway protection. If the patient is dialysis dependent, or there is decreased consciousness level, or if there is multi-organ failure or uncorrected acidosis or hypothermia. So these are the indications when the you transfer the patient to ICU.
So
So
only plain NS is ideal here. Can't give oral because
yes,
lactate varies.
yes, yes. Then key to successful management is early recognition, high degree of suspicion, early referral to the secondary care, early start of the treatment, and annual training in use of Muse chart. So
Okay.
Muse chart is the chart where they early record the patient's vitals. So it's a big
Yeah.
chart where they record everything. What are the vitals? What is the respiratory rate? What is the urine output? All that, and
Okay.
all this results in reduction in maternal mortality from sepsis. So what are the common organism causing sepsis and puerperium? So the most common organism, again a recall question, is gas. That is group A streptococcus or streptococcus pyogenes.
Okay.
So this has been asked. It is the most common organism. Second most common is E. coli. So if you do not have gas in the option, then E. coli.
Okay.
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 Then other organisms are Staphylococcus aureus, Streptococcus pneumonia, MRSA, Clostridium, and Morganella species. Okay.
Okay.
E.
Okay.
coli, this gas and E. coli you have to remember.
Okay.
Then antibiotics should be started within 1 hour. This is again a question. You have to start the antibiotics within 1 hour of when you are
Okay.
suspecting, not
Okay.
waiting for the result. When you are
Okay.
suspecting the patient
Okay.
with severe sepsis with or without septic shock, antibiotics you have to start. And
Okay.
you have to give high dose broad spectrum antibiotics. What you give, you usually give piptas
Okay.
or carbapenem plus clindamycin. So usually we give piptas or clindamycin or miroclinda. Carbapenem is meropenem. Okay,
Okay.
miroclinda or piptas clinda.
Okay. Piperacillin is safer in pregnancy.
Yes. No, meropenem is also okay.
Okay.
Then about the different antibiotics, co-amoxiclav, the problem with it, it does not cover MRSA or Pseudomonas, and there is a concern that it can result in necrotizing enterocolitis in the baby. So, uh, if the patient is pregnant, you do generally do not give Augmentin or co-amoxiclav. That
Okay.
we already know because it causes NEC.
Okay.
Then about metronidazole, it covers anaerobes. Clindamycin, it covers most streptococci and staphylococci, including many MRSA and switches of the exo. So this has been asked. So it in the bacteria, it switches off exotoxin protection
Okay.
and significantly decreases the mortality, and it is
Okay.
not kidney excreted, so it is not nephrotoxic. Okay,
Okay.
so it is effective against MRSA. It switches off exotoxin production. Switches of exotoxin production has been asked about
Okay.
clindamycin, and it is not nephrotoxic. So in patients with renal disease or oliguria, where you feel that renal compromise is there because of sepsis, you can give clindamycin. Then
Okay.
about piptas, it covers all except MRSA. So that's why you give piptas clinda. Piptas is not covering
Okay.
MRSA,
Okay.
while Clinda is covering.
Mm.
And both of these, because in these patients, in patients with severe sepsis, there is some effect on the kidney, multi-organ dysfunction. So that's
Okay.
why these both of these antibiotics do not affect kidney. So that's why
Okay.
they can be given. Gentamicin also generally, if the RFTs are normal, it does not cause any problem. But if the doses are very high, you need to monitor. So it has some kidney toxicity. Aminoglycosides we know are nephrotoxic.
Okay.
So the best is Peptas Glinda you get.
Okay.
Then
Along with clinical.
sometimes they ask this also, like what will you give? So for mastitis or breast, like mastitis, you usually give flucloxacillin. That's the best. So this flucloxacillin, at least you have to remember.
Okay.
If it MRSA, we already know that MRSA we give either Vanco or Clinda.
Okay.
Then again, vancomycin for this cesarean section. Endometritis, you give gentamicin
Actually, what
clinda.
is the difference between this one, these two mastitis?
The first one is this is
Oh, the
penicillin
MR is.
sensitive. This is penicillin resistant.
Yeah. Okay. 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 Sensitive and resistant.
Sensitive, you can give penicillin derivatives like flucloxacillin and clindamycin combination. This is same for mastitis. MSSA, you can give this. MRSA, you give vancomycin.
Okay.
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 And for acute pyelonephritis, this has been asked. So there are some extended spectrum beta lactamase producing bacteria for which you give gentamicin.
Okay.
Okay.
Mm.
Toxic shock syndrome, you give, again, this has been asked, you give a combination of flucloxacillin in clindamycin, because clindamycin, it switches off the exotoxin production,
Okay.
and gentamicin. Severe sepsis, so we have already told, either you give clinda, this severe sepsis, you give clinda genta metronidazole combination.
Okay.
Okay. So then this question, read the question, I'll go back to the
Yeah.
option. Let me know when you have read.
Yes, ma'am. Options.
Okay.
Along with the gentamicin, they are asking.
Hmm. Here the catch is ESBL.
Yeah. Mm. So we have to go for this piperazine,
ESBL, I told you, gentamicin.
genta with miro. Okay. Okay.
So the answer here will be answer
Meropenem. I.
I. Yes, it is I. The next question.
Stage post. Yeah. Yeah. Options. Clindamycin.
Yes. It's clindamycin. Next question.
It is MRSA resistant vancomycin options.
You give that.